Okay.
All right. Thank you so much for joining us on today's webinar. It's, I think, the fourth in our series here on Return to Care, and we're focusing on healthcare neighborhoods. And I'd like to kick it off over to Oscar to provide some words of welcome to us all.
Absolutely. Thanks so much. I've been having some connection problems, so I don't mind. I'm on my phone, but computer is still off. I'm glad that everybody is here. Everybody interested in know more about it. This is a coaching. This is a free class. This is like sitting down in a classroom for learning more every time about CQM, how to work properly, how to work that in a way that HRSA is required to be. Again, I thank every single one of you who was able to make it Monday morning and to learn that this session, it's like open the flower, open the opportunity and see and share what can we do to keep going in a more productive way, in a good direction. And thank for our consultant that always giving us the best of them to be able to provide these services to you. And thanks again, Jamie, Michael, and our team, Regina and Angie.
Wonderful. It's our pleasure. I'm not sure that Regina has joined. Regina, have you joined?
I don't see her.
Might be having some connectivity issues. So
yeah.
I'll go ahead and take this slide. Per usual, if you can just enter your name and your organization in the chat room, that would be really great. And we'd also ask, in the spirit of helping to always just get to know each other a little bit better, what would your theme song for the day be in the chat room? We had some interesting conversation talking about rounding the corner into winter and the holidays at the beginning. So maybe that may have inspired you, but anything that's your theme song for the day. Can be work wise, personal wise, whatever is your theme song for the day. So if you are interested in learning more about how to use Zoom, I think most of us know by now, but you can hover over the top right to change your view options. Basically, if you find where the pictures are, where my voice is talking, and you hover your mouse over my face, you can see a couple of things with the string of pictures. So you can turn off the pictures, you can make the pictures the whole screen if you want to. You can place yourself on mute if you're until you're ready to chime in. That would be very helpful. That just cuts down on the background noise and any potential echoes we would have. We do encourage you to use webcams if possible, especially when we take the slides down and are having an open conversation. That way we can really interact with each other. Of course, if you have any comments or reactions to the content, as we're talking, you can put that in the chat room. We really like to see the give and take and the way that you play off of each other in the chat room as well. So feel free to share your perspectives there. And of course, as you know, the meeting's being recorded and will be available for sharing along with the toolkit after our meeting today. So we have just a couple of learning objectives. Sometimes this is like this huge laundry list and it's like, oh my God, how can we do it all? But this meeting is very simple. As it said in the title, it's about healthcare neighborhoods. So what we want you to do is to dust off the elevator speech and to think about this and how you promote your QI projects and results. But the trick comes in to thinking about what's your audience. We all have so many audiences, right? We have our staff, we have our board, we have our clients, we have each other, we have the recipient office, right? So it's about crafting elevator speeches to use in promoting your QI projects and results across the board. Also, we want to name the touch points your organization has with other organizations based on shared clients within your healthcare neighborhood. So this is key, right? In terms of thinking a little bit about why elevator speeches are important. We're all so busy. We're all working through a lot of change all at the same time. And we want you to walk away from here understanding how to liaise with each other briefly and efficiently around these matters. For today's participant toolkit that you'll all receive via email following the training, we have the slides that we're using today, but we also have a cross-cutting report that will be blown up a little bit bigger and separate from the slides for you to be able to identify what's happening right now with the QI project in our region And you can use those materials to have internal conversations about what touch points you'd like to pursue. We also have our just-in-time training materials. We have a couple of items, our usual articles from ASQ and the literature more broadly that we can focus on and to use in discussion. And we also have two toolkits and one innovation set from the Center for Medicare and Medicaid Services. One, how to make written material clear and effective. Wow, that's important, right? When we think about especially communicating sensitive issues with key populations, but also in terms of the things we do internally. This came up a lot in the organizational assessments, right? Like what written process, what written material we have. So we have a tool here to help make that material clear and effective. Also, chronic care management resources. HIV is a chronic disease. So in terms these days, and so thinking about how we can manage chronic diseases, especially as they pile up in our older populations, right? And for those of us who are getting over the hill and beyond, thinking about even our own lives, that juggling act is real. And then finally, an innovation set on accountable care communities. And that's something that is very much tied to the healthcare neighborhood approach that we're trying to pursue here in Achieving Together and in our return to care implementation in Dallas. So without further ado, I'm going to kick it over to Jamie to walk us through our return to care updates. Jamie.
Awesome. Thank you, Michael, and good morning and happy Monday. We can go to the next slide. And we have a poll. Michael, I don't know if you want me to administer this or, okay. Cool. Let's launch this bad boy. Okay, it's going. All right, so we have a couple of questions about our return to care. So first question, I can connect our QI project to the Achieving Together framework. So you could strongly agree, maybe feel neutral, disagree, or strongly disagree. The second question, I can connect our QI project to our regional EHE ending the epidemic plan. And again, we have strongly agree, neutral, disagree, or strongly disagree. And the third and final question for this first poll is, my organization has thought through the dynamics of our medical neighborhood and how our QI project activities create a local safety net. Again, ranging from strongly agree, neutral, disagree, or strongly disagree. And it looks like we've had 3 folks respond. Oh, jumping up to 7, 8. Fantastic. About 52% of responses. Yeah. I love it. We'll give this a little more time. We're at 61%. Let's try and get like 75. So close, 71, 15 responses, 76, okay. 80. I'm going to end the poll and share results. All right, so as we think about our regional return to care QI project, how can we tie that to the Achieving Together framework? So a majority of folks either agree or strongly agree, that's 77% overall. A few folks feeling neutral or maybe disagreeing. In terms of connecting the QI work to ending the epidemic, again, still a majority fall in agree or strongly agree, most of that concentrated around that 56% agree. And then it's a little more spread out as we think about our QI project and how that helps us establish a medical neighborhood. We have some really awesome slides, I think, that help everyone sort of see where their place in the system might be reflected and to help sort of support that. So it looks like it's kind of more in the agree or neutral range as we think about connecting our QI project to that medical neighborhood framework. Let's go to the next slide. Awesome sauce. All right, so just as a reminder, as Michael mentioned at the top of this webinar, we are actually on our 4th sort of convening around this Return to Care Regional QI project. We began with our kickoff We've huddled up in June and August, and here we are, we find ourselves in November. And one of the things we're going to tease for you all here for our next meeting is going to be the poster symposium, where we'll sort of put together more concretely what we want to share up and share out about each agency's work with the QI. And just as a reminder, we're following that full QI project lifecycle, right? We did the first ever regional AA level discovery process, which is how we focused on return to care. We worked through root cause analyses, and then we're hitting the go button and we're working on those tests of change and implementing change. So speaking of change, girl, change is messy, right? And we all feel the feels sometimes. We say a lot, building the plane while flying it, which is fantastic because we're all part of that ground level work. But this slide really depicts a lot of the change that we have grown through together over the course of that QI project lifecycle. So for example, I mentioned for the first time ever at the AA level, we've done a regional discovery process. That is a significant accomplishment, and we appreciate everyone's role in that. We also know that we rolled out some new documents for subrecipients to use in providing updates, and we'll talk a little bit more about that. We have the QI Excel workbook, and we also have the discrete PDSA template. So there's actually a couple of forms to support our work. And then at the AA level, what the CQM team has done is we've created some internal tracking documents, again, to help shepherd, summarize, and track that collective body of work, which will also support establishing a medical neighborhood. How do we tie things to achieving together and EHE? And one of the things we do want to congratulate folks on and acknowledge is that we're getting better in so many ways, right? Adapting to change and new processes and new forms and all this stuff can be a lot, but one of the things we're really appreciative of and we want to kind of celebrate is initially, as we've been working through these QI project submissions, we had a lag time of around 2 months on average to get everything in. And we have cut that down drastically to 2 weeks, which is fantastic work. So thank you for rolling with all those changes and getting those things to us. And as we know, practice makes permanent. So we'll continue to get better. I'm very confident. We can go to the next slide. Awesome. So let's talk about the QI project form analysis. So let's think back to the Excel workbook form that folks submit for their QI project. What we wanted to do is bake in a couple of visual cues and different components. So as we think about that form, here's a couple of things we've noticed from submissions. The purple section of that form is there to provide general updates about progress. One of the things we've noticed from submissions so far are some measurement related pieces. So in some instances, maybe no measurement data or other information is provided. And we're wanting to support what types of measures to report in the orange section of that form. We've noted a couple of instances where folks maybe have a target for their QI project, but it's actually lower than what their current performance data is. So one of the things we've talked about as a team is the first step is adapting to doing this regional project, doing these forms, getting comfortable with them. But then the next step is as folks complete these and fill them out, there's going to be different sort of cues before you hit send, where maybe some things need to be looked at a little bit more in detail, or folks have accidentally transposed a number, or there's a number of things that could happen. We also want to remind folks how to update measurement data in the green section of the form. And we recognize that as we're all going through this change and growing together, some of these QI projects aren't really concretely QI projects, but that's what we're here for. We're here as a recipient for guidance and support. So we'll reach out to folks, and we still are missing a handful. We're still missing some of those QIP materials. We're really wanting to stick on schedule. So again, we'll be reaching out, and we're, as a team, full team is completely available to assist if you have any questions or hiccups. I want to be mindful of time, so I will say we can go to the next one. So let's step it up, right? We're constantly improving, which is the direction we want to be. So using the orange and green sections of the form, we hope folks identify a standard performance measure in place at your organization that came into play during your discovery process. So folks are also welcome to include any segments that are important to discovery. And we do have some subs who are maybe looking focused on persons of trans experience, or they're focusing on particular segments. So that's awesome. Always want to remind folks it's not too late to go back and retrofit data now. But we're also going to have another opportunity. Again, with that QI project lifecycle, we're going to extend return to care. So there's plenty of time, there's plenty of opportunity. We also want to highlight and give some shout outs, AHF, Cali, Legal Hospice, Legacy, and HSNT. Y'all did an awesome job. So we want to definitely give some kudos there and say thank you. A couple other reminders about going in this new direction is just being open about processes and development, because that's the story. This has been my favorite things about QI. It's not often personally or professionally, you get to just be like transparent about where you are, what you're learning, if you're failing forward, if your things are unexpected, what you want to try. You know, it doesn't have to be concretely proven yet, but you want to give it a shot. That's all part of the story. And that's going to be helpful when we think about elevator speeches later. And it's also going to be helpful when we think about that poster symposium. So we want to know all the deets because there's magic in that journey. And lastly, we welcome and we encourage folks. You can always attach your root cause analysis or other documents if they support the stuff that's being reported and tracked in those QI report forms. And we have an example, ASD has done that for us. And that's been awesome. So we want to remind folks that that's also an option as well. I think that covers my first section, and now I'm going to hand it over to Michael.
All right, so here we have the framework for achieving together. And one of the things that we pointed out repeatedly about achieving together is the wonderful social determinants of health framework that is included. And that it's also a status neutral approach to thinking about this. So, you know, we've teased out here some of the points that have come in from your projects related to mental health, substance use, income level, housing status, education level, criminal justice, demographics, other things that are really tied to this framework so that we can start to have a 50,000-foot view for what's going on within our own environment as it relates to return to care and how that overlays with achieving together. So on the next slide, what you'll see is this circle document, but in Post-it note version. And what you'll be able to do is to see how each of your projects line up with that. So this is small, and we don't have time to go into extreme detail on this. And we also have Michael Hager's crazy abbreviations. So I'm very sorry about that. But with limited space, I wanted to make sure that we have the opportunity to see as much as possible. So as promised, we have those 6 circles from the Achieving Together framework laid out for us to look at what we're actually doing for our projects. Now, you'll note that the cultivate a stigma-free environment was left blank. And I did that strategically because while there are things that are tied to stigma or related to stigma in your documents, the documents themselves didn't explicitly call out stigma. So this is an important thing from a framework and a logic standpoint, right? Like if we were going to talk about what it is that we're doing as a whole and how each of our constituent 11 subrecipient organizations are playing into that whole, we want to be able to have that line of evidence. So we would want to see, you know, in some of your materials, if you really are working on issues related to stigma, hit that ball, hit that nail on the head for us so that we can see that coming out of your documentation. But I wanted to point out that in terms of addressing mental health, substance use, housing, and criminal justice issues, we actually have quite a bit going on in our region and the projects that we have in place. So ASD has its housing graduation program. Legal Hospice of Texas is increasing its services to specific Latinx and the 13 to 24-year-old populations because there is a lot of need around these social determinants issues for those specific populations. And they've also identified that they don't have as many folks enrolled in their services from these key populations as would be expected, considering the amount of people in these groups that are in our population and the needs of those groups. So brava. Legacy counseling is trying to decrease the no-shows among its clients. And this is really important when we think about that complex that screams out of the literature for us, that the main reasons why people are not retained or don't achieve viral suppression are related to behavioral health and housing. And the intersection of behavioral health and housing issues really are the leading drivers of viral non-suppression that we find nationally. And this, like I'm sure would play out if we looked hard within our own data, which you're not expected to do. But just in terms of thinking about why this is important, we see this everywhere. Parkland increasing the patient use of MyChart and really giving the patient in their own hands their voice in terms of how they can interact with providers, interact in their own healthcare. That's really important, right? Because so many of us don't really feel that healthcare is something that we are free to interact with. There is like a structure of authority in place, and normally we go and we're talked to, you know, or instructed by, but it's not something that's truly interactive from the patient's standpoint, or the patient doesn't see that. So, you know, we can see this new opportunity for learning and sharing from Parkland in terms of their use of their patient portal. Brian's House has new data tools to be able to talk about how the services that they're providing really are impactful and supporting the other services that are happening clinically. HSNT is revising its medical case management call queue. So we could go and spend an hour or more looking at this chart, and I think that it would be really interesting to try to pull out where some of these connections lie between our programs and activities. And unfortunately, I don't think that we have that time today unless we want to stay on, and I'm all for that. And we can come back to this slide. But I do want to point out that the two items on the side, the pink and the orange, really are more about the systems issues, right? And we've been very upfront throughout that, yeah, it's expected that subrecipient organizations will be meaningfully involved and participate in this project, but we want to demonstrate to you too all of the different things that we're working on in order to be able to support you in these activities. So the activities that are happening through the county and the state are mostly listed on the sides here. And I think it's really important for you as you know, subrecipient agencies in our region that are also participating in this project to think about how you can leverage these or how you can provide back critical feedback to the county, to the state, and say, we know that you're trying to do this, but it doesn't work, and here's how. That way, we have the opportunity to do our own improvement activities, right? It's great that we're putting together this project. That's an improvement activity itself, but we should demand more of ourselves as the county, and we should demand more of ourselves as a state too in supporting you all. So we wanted to include that here too for your review. In terms of promoting the continuum of care, we have a lot of different neat foci that are pulling either specific subpopulations and how the subpopulations are performing in the continuum of care, or we're looking at new tools, especially community dental. It has a brilliant idea, and so does Brian's House in terms of thinking about how the services that they're providing actually form their own continuum that support the broader clinical HIV continuum of care. And we've talked about that, I think, in past webinars as well, and can provide additional supports if you're interested in you know, kind of chewing that fat with us. Finally, in providing culturally appropriate prevention, care, and treatment, we have a lot of items here that are focused on that. And you might ask, why do we have items in magenta but not items in blue? And again, I want to focus that, yes, providing culturally appropriate care is closely tied to stigma, but we do have a lot more in terms of actual interventions and actual research now around stigma. So we can think about stigma as it relates to what we do and our actions, our beliefs. As providers, we can think about this in terms of individual self-stigma, and there are a couple of other things too that we can push on if we wanted to. I don't say that we have to again, because there's a lot going on here. There's only 11 of us, right, in terms of our subrecipient agencies, and we have a lot of action. It's our first one, and look how meaty we're being. Congratulations to us on that, I believe. All right, let me get rid of the doodles here that folks have made, clear all drawings. So this document, this image here is meant to show how well connected and how overlapping our activities are. So hold on for a second, because I'm going to take you for a ride. When we think about the specific activities that are being proposed and the types of services and activities that are being supported by our QI projects in our individual agencies, we basically fall into several groups: clinical HIV care focus, a focus on social determinants of health identification, a focus on behavioral health services, a focus on legal services, a focus on oral health services, and a focus on housing services. And it shouldn't be too much of a surprise that, yeah, community dental is focused on oral health services, or legal hospice is focused on legal services. But one of the things that is surprising is that, you know, the size of the bubbles here is related to the number of groups that are focused on an issue. So yeah, we have multiple groups focused on certain issues. But what's very interesting to me is that what I would want to see or hope to see is that these bubbles would be overlapping, right? Because the whole purpose of the legal services activity, of the housing services activity, of our oral health services activity are to play into and to support the broader clinical HIV care that we're providing as a system. So again, like our real North Star here for HIV services as funded by Ryan White is to think about viral suppression. But of course, we're not all clinical providers, and this has been one of the things that's been challenging for us over time. So it's really incumbent on us to take that community approach, that safety net approach, and to think about how what we're doing actually substantially supports these other areas. You know, thinking about the purple bubble, social determinants of health, that's really important to housing and behavioral health, right? So you'd think that that would be even more overlayered. But what I see when I look at the reports is our projects come up to each other very close and touch each other. Go, ding, your turn. Instead of really overlapping or overlaying in a supportive environment that helps, you know, to show how what we're doing in one agency or program directly influences what's happening in another agency or program. I was heartened to see the poll a couple of moments ago where many of you are starting to think about your healthcare neighborhood. I didn't think that as many of you would have, you know, been so confident in that. And what that says to me is that you're already ahead of this. I'm not presenting you as something new. You're already thinking about how you can do more, how you can do better to integrate services and activities within your organizations, but then also outside of your organizations too, right? Because I think that that's the last thing that's very important to think about here. It's hard to innovate. Change is messy, as we've already discussed. But many of us, especially the clinical HIV care focus agencies, offer a large compendium of services. And so we should be thinking about describing our activities and planning concretely what our activities will be, especially internally, to think about how the programs are scratching each other's backs to lend themselves to specifically HIV viral suppression, but, you know, more broadly to wellness and healthfulness among our target populations. So another item to focus on here is the healthcare neighborhoods piece. We have a really large, expansive area to focus on. And we know that we have one agency that is based, Kelly Clinic is based up in the Sherman area. And we have a lot of programs that are based in the Dallas city area. And we've talked, in talking with many of you through the OA, Jamie and I and the team have gotten a good sense of kind of how many counties or a little bit of the spread. But one of the things that's really important for us if we're trying to really understand healthcare neighborhoods is what services are being provided where. Okay, so in terms of thinking about some of our larger organizations, we know that you have a zillion sites and that all of those sites may not be offering the same services. And so this is something else that we should be thinking about and considering. It may be a big leap for this year, but maybe as we're extending return to care next year, we can broaden our thinking a little bit about, if I have 7 sites, where are those sites? Are we providing all the same services at those sites? And who are my key contacts or my key connections in serving my clients at each of these sites? Because it'll be different, right? We don't all have the same sites in the same counties next to each other. So the style or the, I guess, the group that we're intermixing with to create that very local safety net is going to vary. So it's really important to remember this, that none of us are a giant monolith. We kind of look at each other that way sometimes and talk about each other that way, but it's not true. And we know that. So we should be trying to push ourselves to think about how what we do is really spread and leveraged. Now, for those organizations that play critical roles like community dental and like legal hospice, you may not have sites all over. And so that's one of the reasons why we wanted to do this, is to think about, since you play a critical role in the system of care, how do we make sure that no matter where in this massive area people live, that they understand the existence of your service and how they might go about accessing it, understanding that they may not want to drive 3 hours to go to a dentist. But this is important thinking, right? Especially when we think about new funding opportunities, new collaboration opportunities, funding outside of Ryan White that is focused on EHE, or other opportunities that I'm sure will continue to come down the pike. We have a lot of things that we could do to prepare ourselves for successful future funding, as long as we have this information available to us. So that's kind of like a pocket reminder that QI has a lot of important, substantial, benefits to us and to our client population. It's required, but it also has important implications for the bottom line, for marketing, for advertising, for the pursuit of future grants. So let me see here.
And Michael, I would like to highlight that detail based on zip codes. Data has provided the zip codes where the rate is higher. So some organizations actually go and have a clinic, a provider locally in the zip code that are considered high prevalence. So it is the connection of the services exists. Like Victoria was mentioning, we have a very small sample, 10, and the project is a pilot project versus 8,000. By the way, it's almost 12,000 patients with HIV that serve Ryan White, not 8. But it happened, the collaboration and the know what's going on in the neighborhood, it happened like organic, but it's better if we actually cultivate and reinforce that concept. But thanks for bringing that up. It's important that we have the zip codes and everybody knows the zip code where the prevalence is high.
Well, Oscar, you're already in the crystal ball here, and starting the conversation for us. And I think it's important for us to go ahead and launch a conversation. Let's spend a couple of moments if folks have any other major comments, concerns, things that bring them hope, any fears. Talk to us about the frameworks that we just showed and where you see yourself in the project. I already see great chats coming in about, hey, actually, we are overlapping with some of these pieces. And this is extremely important because we're going to go ahead and update that framework right away, right? So I don't know, you can go ahead and share reactions to the content or, actual results or things that you might tweak or change based on the content presented.
This is Piper. Just a note that we spend a lot of our time in the Dallas County zip codes, but I can't say I know how many clients we serve that live in Cook or Grayson, nor do I even know the zip codes. Like right now, while y'all are talking, I've been Googling zip codes in Grayson County, zip codes in Fannin County. putting those pieces together sometimes versus, just the name gives me from the kind of how do we go back to our data team or how do we go back to look and see which clients live in those areas, put it all together. Because many times I forget how large, we know how large our patient base is, but just like where they're all distributed and, kind of putting the anecdotal back to some more concrete data of knowing how many clients we serve in those outlying areas.
Jamie has her hand up.
Yeah, thank you. Zip code data is one of my favorite pieces to start folding in because it does give you such a particular picture of what's happening in a given area. And one of the things as Michael had the map and our friend there in the red stars, one of the pieces about as sites have or don't have, if you have many different locations or satellites, it makes sense why some services are offered in some areas, but not others, right? That might be rationed in like what folks are wanting to access up there, et cetera, et cetera. So what's interesting about where those different locations are different in their service portfolio, this can also tie in when you get to the A in your PDSA and you found success with stuff, figuring out what do we adopt? What do we want to roll out and scale up to other sites or to other staff, other providers, but also where do we maybe need to adapt it a little bit because the folks up in the rural clinic are going to be different than in the metropolitan area. So when we think about that spread as well, there's a lot of application once you get to the A in the PDSA cycle to sort of apply that information. So.
Let me see if I can.
Victoria has some great questions in the chat room. And I think Oscar already answered the one about the relative sample size piece. And that can't be ignored, I think. When you think about this project and for tablets and how that is only a small portion of the bigger picture, as Oscar mentioned, it's about thinking about how this can expand, right? So you're using the roughly 10 people as a learning laboratory to identify where your system has strengths and where it has opportunities for improvement based on what this group of 10 is saying to you and the outputs there. You may determine this is really great, it needs to be spread. I would like more tablets, please. Or you might determine, this is an important intervention for people who have very specific issues and very specific characteristics, but it doesn't work as well for everybody. So there's a lot of different ways that you can apply learning, and there's a lot of different ways that you can focus learning based on the context of this pilot. The question about whether you have the tablets or not, we can focus on that in the background because there's only 3 organizations, RCD, AHF, and you at PRISM. So if any of you would like to kind of just weigh in, if you've gotten them or not gotten them, like just to answer Victoria's question, that would be great because it's another important metric for our process, and we know that we've had some delays with that too.
Michael?
Yes.
Hi, this is Joni with AHF. How are you today?
Good, how are you? Happy Monday.
Good, happy Monday. We received the tablets and we have identified so far 4 individuals who are on our 13+ month out of care list. And we brought them into the clinic and some have scheduled appointments. And unbeknownst to us, we were unable to distribute their tablets because we did not have the agreement or something from Nathan at Continued. So we brought the patients in, but had a delay in being able to distribute the tablet. So we have connected with the patients, but it's unfortunate that they weren't able to be given the tablets and trained on the first day, because when we contacted them, we communicated that this process was going to be such and such and weren't able to sort of follow through with our word. So it makes it a little frustrating when you've tried to connect with someone and bring them in. So that delay was unfortunate, but our CQM team met right away to come up with a solution. We think we've got one. We should be able to roll forward with it, but it did create a little bit of a failure, I guess, if you will, a failure forward, because we were able to resolve it and moving forward. But so the tablets are wonderful if we can just get them in the hands of the clients
just
and
get them out
trained in using them. But staff has been trained, so little bit of a challenge in the road, but not something that we couldn't overcome. So just wanted to kind of put that out there in case anybody else is experiencing some difficulties. But on a positive note, out of the nearly 80 people that we have been reaching out to, out of the first 35, we were able to secure 4. And one really positive note, one of the clients was actually in tears. And Hosea, thank him for making some of the calls, most of the calls, was able to connect with someone who said, I'm so thankful that you reached out to me, and this is wonderful. So it's almost like they were waiting for someone, felt very isolated, hadn't really had contact, and we're just really thankful to be reached out to. So in a sense, maybe there's some lessons to be learned outside of just bringing back into people from care, but really just connecting with those patients who may have been absent due to COVID, or we may have noticed a change in their behaviors. I think there's a lot of mental health concerns and depression going on with people. And so this person really just needed that connection to be strengthened and is very happy to be back in care. So positive outcomes, and really happy. I thought 4 out of 35 was tremendous. Didn't really expect even that many. So thank you.
Beautiful. Thank you for sharing that.
Absolutely. I would like to add detail on that, Johnny. Thank you, Chef, for that detail. The process, the pilot is a pilot. We will discover those hiccups. And the purpose of those discovering and sharing those hiccups is to overcome them. And for Prism, what we are waiting on Prism is the signature for the agreement that Prism has connected with Continued, and that is delaying. Your signature is delaying the shipment to yourself. So, I mean, keep an eye on, ask Kathy. She knows that, but she's on top of that piece. And another detail that is important on that distribution and connection to the network is the distribution for the zip code connectivity is actually laid out. South Dallas has poor connection, and Prism knows that. We shared that with Dr. Morris Harris a while ago. And there's an access for that piece as well that you have to take into consideration, comparing the zip code of high prevalence versus the connectivity, and how feasible is that tablet zip code with low connectivity. So there's a different pieces of the puzzle that you will provide back to us, and we together are going to put it to function. And this is a pilot, and thanks for the feedback. We need more of that. Thank you, Victoria. Thank you, Johnny. Thank you for RCD to connect that, and the comment from Norma, and for Legacy as well.
Thank you, everybody.
Yeah, this is Dell. I'll just say a couple of things about where we are with at RCD. So we have received our 2 tablets where the Continued people have been very available to deliver the training that we need on those tablets, but the delay is really on our side of getting the staff people who are going to be involved here assigned and available for the training, because I'll be in the training as probably our campus coordinator will be, but it'll actually be someone in the clinic who serves as the contact person for the 2 clients we're going to assign these tablets to. So we haven't, we're not doing a business associates agreement directly with Continued. We're going with Dallas County on that arrangement. So they've been available to do everything on their side that we've needed them to, and more than available to do the training, which we haven't quite picked a date to commit to. But so that's where we are with it.
Thanks so much for fishbowling, with us, because I think it's really important for everyone to be able to see a little bit, how is this working within our own sites, and across sites. We all have our own individual culture. We all have our own individual business process and systems. And it's unreasonable for us to come in and be like, punch, punch, punch. You have to do it all exactly the same way. And this conversation has been really wonderful to be able to hear a little bit about some of the concerns and how they are similar or different, for this one project aspect. So, I think that we can look forward to having more deep conversations like this as we roll forward. But right now, seeing as we only have 13 minutes of scheduled time left, I'm going to kick it back to Jamie to talk a little bit about the crafting of our elevator speeches.
Awesome. So yeah, let's think about this. We'll kick this section off with the poll as well. So let's hear what folks think. First question, I feel comfortable crafting elevator speeches to describe my work. And this could just be in general, right? It doesn't have to be necessarily about the QIP, but just that comfortability. So that again ranges from strongly agree, agree, neutral, disagree, or strongly disagree. Our second question, I believe elevator speeches are an effective communication tool. Same scale, strongly agree, agree, neutral, disagree, or strongly disagree. And then finally, third question, my organization has a set of elevator speeches developed to communicate about our return to care activities. Again, strongly agree, agree, neutral, disagree, or strongly disagree. We've got about 50% of respondents. Y'all are clicking away. Amazing. In the poll and share results. So let's look at our comfortability with elevator speeches in general. So about 50%, most folks agree. When we look at agree or strongly agree, that's 75%. But we have some neutral parties and some folks who disagree. And it took me a hot minute. I used to dread elevator speeches, so I would have been disagree. So second question, in terms of believing in the effectiveness of using elevator speeches, here we see a little bit more of a spread between feeling neutral, agreeing, or strongly agreeing. And then finally, in terms of have we thought about crafting elevator speeches yet specific to this return to care? So majority of folks, 56% would say disagree, a handful there strongly disagree, and some neutral. So this is awesome. This actually leads us into our next set of slides. I may need you to advance the slide, Michael, my friend. So here's some tips, and we've talked about this before, so you might remember this, but in terms of elevator speeches, practice makes permanent. Again, we can see that here, and you can break this down. So one of the things we want folks to keep in mind is you can use the 27-9-3 method for how do you sort of create something that's succinct and brief, but contains the information that you want to communicate. One of the ways to increase your comfortability, two, also the effectiveness, is to develop different speeches and to think about the audience. Is this internal or external? Test this out at your multidisciplinary staff meetings. Hey, it's time for the care services division update, or hey, it's time for the housing staff update. Practice this out maybe internally with just some coworkers and colleagues. And again, this is reflected on our OA scores. How are we sharing up and sharing out in our organizations about our QI activities? We also have external audiences, maybe some patient advisory or community advisory. Maybe some of us sit on subcommittees at Planning Council. So there's other opportunities to talk about the work going on. We have our community groups, professional groups. We have our boards. We have lots of different audiences. So thinking about tailoring what's effective for them. One of the things that I did on a previous learning collaborative, which is actually where I met Michael, it's called H4C, we did different elevator speeches, and we had one that had to do very clinical, patient outcome based. What were we trying to achieve with viral suppression? We had another elevator speech that we used with our social workers, and it talked more about the human component and the human story. So it was less outcome focused, and it was more about sharing that individual meaning in one person's life. And then I had sort of my C-suite money people elevator speech. That was all about how many dollars is this saving you? Because whatever is persuasive or a good communication tool is going to change based on the audience. So a couple of things you can think about in terms of like, what do I say? Especially since so many folks have yet to form elevator speeches about this QI project. You can ask yourself, why is there a regional QI project and why are you part of it? Pretty simple, but super helpful. Why are you working on what you're working on and what's the end goal, especially as we see different subpopulations being of focus? And then is there a role that the group receiving the elevator speech can play? Ooh, mama likes this bullet. This is a hot ticket bullet, and I like this one a lot. This can be very effective and very helpful for pulling people in a subtle but meaningful way. Let's go to the next slide. So we drafted up a couple of examples. We'll go through these really quickly. The first one, this is an example. So the Dallas EMA launched its first ever regional QIP focused on retention and HIV care. This is linking Achieving Together, USEHE, and the QIP addresses the service system ability to address social determinants. To me, this is a great audience for as we share with other AAs, other Part Bs, other funders, because again, we're tying all these big initiatives and things together. This second one, I think, is a little bit more, maybe organization or community focused, and that's HIV provider organizations around Dallas are working to address structural barriers to client engagement in HIV care. Together, their community-focused efforts are paving innovative new means of reaching and serving clients. This is all talking about working together. And then the last one, which I also like, is our regional QIP is being extended through 2022 to help our provider agencies with new expectations. Extending the project helps provider organizations focus on enhancing their role in the HIV safety net. So this is very sort of provider and subrecipient focused. Who's benefiting from this project? Why are we doing this? How is this helpful to us? So you can sort of see playing around with these elevator speeches and different audience types. We can go to the next slide.
And while we're transitioning, I saw a comment from Kelly in the chat room about 2793, and that's my fault for skimping on details based on the shorter time frame. So we've talked about that in some of our trainings before, but in short, we're looking for around 27 words, 27 seconds, about 9 words per sentence, and about 3 up to 3 main kind of content points or sentences. You'll see that ours were actually more 2 sentences or kind of 2 main points that were grouped together. It's really challenging, to do exactly 2793. And so per usual, use that as a rough goalpost. Don't force yourself into the mold. But back to you, Jamie. Sorry, I just wanted to pull that out because I thought it was really important that Kelly raised that because she's right.
Yeah, and it's an exercise in brevity and targeting your audience, because we often get trapped in writing grant reports or narratives or really long, extensive things, but this helps you sort of sharpen being able to be more succinct. So we can give maybe 1 to 2 minutes if folks want to practice or give it a go. Maybe some of the folks who responded that they had started forming some elevator speeches would be comfortable enough to unmute themselves and test it out.
Sharing is caring, and we're in a very safe space.
And if folks don't feel like ready to do that yet, if there's like, here's where I'm feeling uncomfortable, or I'm not really sure what group to practice this out on, we can have a little discussion as well to help get you over any hurdles you may be feeling.
Hi, Jamie, this is Joni. How are you? We don't have an elevator speech in reference to this QIP, but something that we have experienced the speeches for is we changed our name recently. And so we had an elevator speech that we put out to all of our staff in terms of when you're speaking with clients, this is what we would like you to kind of say. So we sort of passed around a paragraph and said, stick to these talking points when looking at our name change. And then something different to the external stakeholders, maybe a little more involved, just about why we removed, we were AIDS Interfaith Network and have been for, almost 3 decades. And now kept the acronym because we're widely known by AIN. But we now, the acronym stands for Access and Information Network, kind of going along PRISM Health North Texas, as I'm sure you know, was AIDS Arms. A lot of agencies have done that. And so sort of in that movement. And then we also moved and added a healthcare center in the last year, 14 months. And so that is something that we also had sort of an elevator speech. So I think that having done those previously, we're comfortable in developing those and comfortable with staff sort of disseminating them out to staff and explaining that, this is something that we want you to communicate with stakeholders. This is something when, general public or, media outlets, those kinds of things call. So we kind of had different scenarios in which we provided different elevator speeches. So I think that's important to communicate a congruent message when you have agency-wide changes or things of that nature that not only change things for stakeholders, but change things for the client. So don't have one prepared for the QIP, but think that we're certainly comfortable and just sort of wanted to mention that about kind of experience. And it is difficult at first, but I think once you do it a few times, it's like second nature and you almost remember them like your favorite song.
Yeah, that's a fantastic parallel example. So transferable skills, you know, and you've been able to practice that and do those for different audiences as well. So that's an awesome example. Thanks, Joni.
All right, let's round the corner here in our last few minutes and talk about our next steps. So we have an action planning form that we often have available. And the things that we want you to focus on this time to help you to continue to refine your project is, how will you briefly describe activities related to the healthcare neighborhood, return to care, and achieving together activities? I think it's so great for us to be able to talk about how we're part of something bigger than ourselves and to reassure clients that, you know, and other stakeholders that we're on this. You know, we're all working together to meet your needs, and we're all ears for opportunities to see, you know, how we can do better by you. Does your organization need different elevator speeches for different audiences, or talking points is another way to think about this. But that might be important to kind of like just kind of chew on a little bit with your work groups. What additional internal or external touch points do you have? You know, and have you brought to your program and clients? You know, so thinking about the conversation we had earlier related to social determinants of health, you know, how does that relate to ways that we're working better internally and ways that we're working better externally with our partners? Are there any other elements from other organizations' QI projects that you would want to try in your setting? So again, if we have time and folks want to stay on for the next 30 minutes, we can talk about that more in depth. But even reviewing, I know that you all have each other's contact information. So even reviewing that, the document when you have it in hand and making those calls, maybe you'll be interested in exploring with each other what it is that you're doing concretely and how you might be able to port over some of those ideas. And then, is it possible for you to describe your organization, you know, and the project in terms of USEHE or Achieving Together? And so that's a little bit different from, you know, number one, where talking about how you're related to it is different in terms of how you're actually, you know, describing it in terms of that, right? That this is achieving together versus this is related to achieving together. So you may or may not decide that any of these are appropriate for your agency, but we wanted you to have this, you know, guide just to kind of like for you to think about and to chew about what's appropriate for my agency and our next steps in our QI project. So we only have one presentation left, and that's going to be the poster presentation. And since we are pivoting here to extend return to care, we want to focus you on, you know, this midpoint, basically. As we've noted, there have been some kinks in our rollout of the project. And for those of you who have tablets, you've only really just gotten them. So we want you to feel secure that this is meaningful. This is going to do something, folks. This isn't just checking boxes. You know, we want to really lead by that example and to allow us that space to be able to think about how this works. So the poster presentation, instead of being an endpoint, is a midpoint. And you should base the content for your presentation based on your action planning documents. Hopefully your organizations have been, you know, filling this in over time, but we have them in each of the toolkits. We could also provide them to you as a set, if that's helpful for you to kind of like rework that or go over that, to think about what you might want to put in your poster. The QIP report forms that you've submitted, and especially thinking about that progress over time. Were you submitting data? Were you not submitting data? Sometimes the idea that, you know, there wasn't data, but now there is, that's a huge gain or a huge step up for your organization. We want to know about that. You know, we also want to know about the feedback and that you've given to each other and that we've given you and how that's influenced your project. If you have available step measure or other general performance information that you've used to track this project, You know, again, we'd hope that you've been putting that in your QIP report forms, but if you haven't, that's okay. Go ahead and add it to the poster. Don't make perfect the enemy of good. Do what you can do when you can do it, and understand that we're all learning together here. I think it's really important when you build the poster that you want to have a box on limitations. You know, to Victoria's point and, you know, others, that we may be only looking at a small subset instead of everybody. And we're trying to create a framework to generalize or to extend or spread, but it's a limitation. Tell us that. Tell us that, you know, you started at a place where you were very, you know, data poor, or you had a lot of data, but you were data rich, but information poor, right? That's an important limitation for you to include. And it'll be a sign of the way that we're all maturing and growing together. And then the spread and replication of your project would be another important thing, especially as we're thinking forward to next year. You know, if you're focused on a specific subpopulation this year, are you going to maintain that focus, or do you think you might shift it? If you might shift it, are you going to go through another discovery? And things like that. It's important for us to take where we are and see what the next step can be. I think a lot of us have focused on conversationally that quality is a cha-cha. You take 2 steps forward and 1 step back. And that's a natural part of the dance. Exactly. You know, and there's nothing to be ashamed of with that. So it's important when we build the posters to include information that will be helpful for our own understanding of the project. We can use it as a communication tool with other stakeholders, including each other and the recipient. That's the main reason why we're doing it. But of course, you'll have it available to describe your work and your activities and your outcomes to other key stakeholders. So by the time we get to January, we'll have a new calendar worked out. We'll be talking about this with the external quality committee on what's appropriate in terms of the cadence of our supports that we provide to you next year, because we don't want to under support you. We also don't want to be the flies buzzing around your head over supporting you either. So important conversations to come regarding our next steps. So I'm not sure if we had questions in the chat room or reactions. All right, I can see.
Mostly just a cha-cha.
Oh yeah, cha-cha-cha. I mean, it can be frustrating, very frustrating sometimes, but understanding that like it's part of the process, you know, and that like, you know, just like anything else, to learn takes time. And, you know, yeah, it takes time, it takes patience with each other, especially, I think is very important. All right. Yes, we will be publishing an official format for the posters. And it'll basically just be loose guidelines that we're looking for something that's not a single PowerPoint slide itself, but something that's actually more of an actual poster that we can you know, kind of look at and interact with. We understand that different people and their organizations have different constraints. So if it's a series of PowerPoint slides, that will absolutely be acceptable. We would never set anyone up to fail like that. But we are hoping that we can have things that feel more like if we were together, you know, 2019 style, like what would that poster look like? You know, so we'll have very general, you know, kind of expectations that are laid out, but those expectations will still be loose enough to allow all the different organizations to credibly and meaningfully say what they have to say. With, again, we don't want anyone feeling like they have egg on their face, because none of us do. Of course.
Hey, Michael, this is Dell. I have a question about the posters, just looking ahead. So
Yeah.
we'll each be doing a poster, and then is someone integrating those into a master poster, or is it just, it will stay individual posters?
Great question. I think Oscar is very interested in creating an aggregate regional poster, because then that's what they can show, that we're in this with you and we're doing it too. We're not just making people do stuff. You know, this is something that is meaningful and credibly adds up to something at the regional level. but we will absolutely maintain each of your individual posters, and it'll be part of a broader kind of like booklet or a set that we can use to describe our work and what it's meant to us as a region. Great question.
Yeah, and since the purpose is, our purpose is improvement, because it's a QIP project, it's a big project. We'll identify those gaps at different levels. I mean, you all gonna bring us, okay, what the limitation has Prism with the business agreement. RCD decided not to take a business agreement that didn't actually delay the process, that speed up the process. So those kind of details is tuning up the machine to work smooth. Thanks, Dale. Thank you very much.
Okay, and thank you, Oscar, and Michael too, and Jamie too. And guidelines will definitely be appreciated. It's been a decade or so since I put a poster together. So
no stress. Don't worry. No sweats.
You know, and we're still recording. So for you know, people listening to the recording, please know that we're here to support you. And, you know, if you want to have a sidebar with us, you know, where we kind of talk about what you might want to put in your poster, we are absolutely open to that. You know, again, we're very supportive of each of you and your efforts. And we don't want anyone to feel exposed or that they have egg on their face, because none of you do. We're here for you all the time, 100% of the way. So I'm not sure if, thanks, Jamie. I'm not sure if anyone else has any reactions or comments to the frameworks that we had kind of thrown up earlier. We got quite a bit of additional information shared with us related to those social determinants of health bubbles. And that's going to be helpful for us to think about how, you know, we talk about our work. But I just wanted to throw this up one more time to see if there's any other kind of thoughts, reactions, and ha, that, you know, that folks would like to share or emote around this.
well, this is Dell again, and one of the things I noticed is looking around for like other places or other sticky notes where Resource Center might appear under the promote the continuum of care. Our project very much has to do with helping people who test positive through our prevention program into appropriate HIV medical care, either at our medical clinic or within the Ryan White system at other medical clinics, et cetera. So, you know, I could have seen a sticky note there under promote the continuum of care. Although I'm perfectly satisfied where we did appear under the provide culturally appropriate prevention. I imagine other people too might have seen areas, you know, but that was the only place that struck me as far as my own particular project, where I would have maybe stuck myself too, would have been in the blue-green area.
That's great. I have captured that note, and you know, we had so many comments in the chat room that we're definitely going to take this back. I think it's really important that, you know, just like we're asking you guys to periodically consider the framework that you have, periodically consider what the data is telling you about the framework that you have. We're putting that same onus on ourselves. And so this is our way right now of sharing back to you. And we think that it's pretty good, but there might be other things too that you would, you know, want from us in terms of you want to see something else too on how what you're doing plays into something bigger. So, you know, one, it's important that we keep collecting this information as it occurs to you on how we're working as a system on these issues. You know, and it's important too for you to provide us with any additional feedback that you're really looking for something specific from us in terms of how we can describe what's happening overall in the region. So both of those levels, we are all ears and very receptive to comments that come in on your forums, and also comments that come conversationally. And I think many of you have already encountered, our questions that we're kind of following up with some of you on when you submit your QIP form, or when you submit your PDSA worksheet. Just as, just so that we can help to broaden our understanding of what's happening, but also to help you to include those really vital details in your descriptions that will be helpful for, let's say 10 years down the line, you're no longer there and someone wants to look back at what happened now. They could pick up these documents and have a really clear sense of what you did, how you did it, and why you did it. So all of that is really important. And thank you, Del, for that note on, basically a rapid start framework that you have. Hi, Kelly.
Hi, I just wanted to chime in. I'm sad that he's not here today, but I'm going to forward him the next meeting invite if that's okay.
100.
Jonathan Goot was promoted late last year. He was in charge of the Village Project, and now he is our outreach and retention manager.
Mhm.
And because Parkland recognized probably or around the same time Dallas County did probably, that our viral suppression numbers were strangled by our retention numbers. So because retention wasn't moving and we knew that retention was having a great effect on viral suppression, we weren't able to get above that 82, 83, 84% viral suppression. And I think that one of the things that, and Jonathan can speak to this better than I can, and I'll let him when he comes next time if y'all want to hear about it. But one of the things we're kind of having little epiphanies on is to really try to catch the people before they fall out of care. Because when you're a bigger place like Prism or Parkland or AHF, you tend to have not enough people in the world to keep hold of the missed appointments and who's, all of that. So we've actually added 2 more members to the outreach team who are going to be funded through program income in order to have them become outreach and retention and make those calls to people who didn't show up for an appointment today and remove any barriers. And we're hoping to put our outreach group out of business just by having a retention team that can actually keep people in care and bring them back to care. So
I love that. I love that. You're taking basically a change management approach to examine what roles we have and, how do we actually interact with our clients through those roles? And then you find opportunities to shift tasks away from one unit or department, that's reactive into more of a preventive, and proactive. I love it. And to the point that was made earlier, a lot of folks in different regions have used this type of information just as you've done, to say, we can definitely afford to fund additional positions here, or, we're going to do bridge funding, and our goal is to seek funding through EHE or through the Clinton Foundation or through some other group to make sure that we can fill and create these new FTEs in a sustainable way.
right. And because the funding for outreach has, just incidentally, not complaining or anything, but because it's been reduced, it's actually kind of freed us up because we're not constrained to that 6-month mark, except for the units that we're going to bill to the grant. So we can look for people who've been out of care for 4 weeks or 6 weeks or 10 weeks or and try to catch those, because the further you get away from a person's last visit, the harder it is to find them and bring them back into care. And 6 months might actually be too long. That might be a discussion for the Planning Council to talk to them about changing that so that returning to care can happen sooner. But yeah, I think that I think you really kind of need to think out of the box and think back to the cause and effect of it all in order to, I saw a quote on the internet recently that really just kind of opened my eyes and made me go, wow. And that was, we need to stop pulling people out of the river. We need to go upstream and find out why they're falling in.
Amen to that.
And
Mhm.
I just think that's kind of how our thinking has evolved around here, is we really need to see why people are falling in the river and stop that so we can stop having to pull everybody out.
I love it so much.
I would like to highlight that detail that Kelly's mentioning. You can use the no-show rate per client, per individual, to see, okay, that's the tendency, it's a pattern, and there's a lot of data that you can play with when it comes to clients who are about to fall out of care. You can create the last visit, the last appointment, the last two, or you'll be creative on that, and it's fantastic. I know the point is bringing Jonathan Good in this is the connection with the Dallas Task Force. HIV Task Force is connected. He is connected with that, and that'll be exactly connecting, overlapping circles. And QIP project is actually connected with the HIV Task Force. I'll be fantastic to have him over.
That would be great. Michael, I'll send you his email address if you want to go ahead and send him the original invite next time when you send him out.
Sure, 100, please.
Okay, great.
And the point of Norma mentioned that comparing rural areas and urban areas, the adherence rate is different, the problems are different, everything is completely different. She's right, you're right, Norma. It's the dynamics in the rural community, they call rural, in the urban, it's completely limitations, transportation, mental health, access, mentality, and health literacy. The level of literacy in the health varies tremendously, varies on culture, based on different variables. But thanks for highlighting that. It's true. It's completely factual.
You know, to Norma's point, she's like, I had no idea. That's one of the reasons why we're digging around and scratching at the dirt here, you know, in the data, to the extent that we can. And, you know, for some of our agencies, that's meant like, oh, snap, I have to build out a lot more data to capture things beyond just utilization data for the purpose of auditing and billing. That in fact, you know, we have so many opportunities to really make our visions and our organizational visions and missions sing for us based on a project like this. And, you know, it's up to us and our own innovation and creativity and our own internal discussions and process to kind of make that real for us. And it'll be very different from localized area to localized area and from agency to agency. You know, the one thing that I'm sure that because we have so much experience on the call, we're not going to run the risk of this as some other regions do, but don't bend yourself backwards to try to come up with individual project elements for each of your individual sites. You know, we're trying to ease everyone into the water. So think broadly about your services and, you know, how you can do one thing that'll affect as many people as possible or as many sites as possible. You know, thinking about that Pareto effect, you know, don't make perfect the enemy of good and do what you can do when you can do it. You know, these aren't just silly mantras that I spew all the time. Like I really believe that. And that's how we're going to be able to move forward sanely and do some good work at the same time. So we've already captured quite a bit of perspectives on this, and I think I'm pretty confident that we're going to be able to talk about this moving forward in more of an overlapping way. That's going to be really neat to visualize and to see. And I think it's very heartening for groups like the Planning Council and the Task Force to see that, you know, there's a sense that we are very much entrenched in our shops. And that we don't work as much together as we could. And so starting to counteract that cultural belief that, you know, they're not working together and to actually show them receipts like, oh, yes, we are, and here's how, I think is going to be huge for the psychology of people living with HIV, at least the psychology of people living with HIV involved in decision-making in our region. So I think that's really helpful. I'm just wondering, any other reactions to this piece? As we pointed out, we already got quite a bit in the chat room around that. So just wanted to shake the can one more time. Any thoughts or kind of hum and ha around this this element? Oh, go ahead, Del.
I was really going to go off on a different track, Michael.
Okay, yeah.
But if you leave the schema up, then that's great. So I was the person who asked what was due to materials to be submitted on November 1st. Jamie answered that question, and I believe I put at least a good part of what I had at the time in glass cubes a month or two ago. But I still struggle, and we've talked about how can we streamline where everyone knows what's due, when, who does it go to, etc. And I have to say that, so I was a little surprised when, and I'm sure I should have been perfectly well aware that something was due November the 1st, but I still sort of struggle with that. And then when it, and then where to put it, who to let notify that I've put it somewhere, etc. So I don't know what, if there's any current think we've talked about maybe either a newsletter or regular email that goes out to people or something, but creating a one pager, Regina says. So that would be very, very helpful to me. And I'm sure I don't have to track due dates and materials for more across more areas and programs than anyone else does, but it would be very good. And then I think someone said they're sending whatever, Norma, I've been sending my stuff directly to CQM admin. Is that the place? So this is a good question right now. I think I put some of my stuff into glass cubes under the materials area. So that would just be helpful to me to have a better sense of what's due, when, where. So, and I guess Norma's asking too.
I think many of you have asked that, and I just want to kind of just be upfront and clear about that. That, you know, that's part of Jamie's slide where change is messy. You know, we apologize for the dust in the air that's kind of like sometimes get in our eyes too, and it's in our mouth. You know, and that I think is one of the challenges of kind of instituting new process, as I've described before, especially having individual conversations with some of you. Yeah. At this time, we're looking to have the QI materials ideally submitted to glass cubes. But as we work our way through, like we don't have that one pager yet.
Okay.
And so we don't have a system at the AA level that will be like, okay, now we're going to send an email a week before things are due, which is another thing that quite a few of you have asked for, you know, like a prompt. And if I don't need the prompt, I'll delete it. Yeah. You know, so, you know,
okay. Well, that's, you know, that's more than covers, you know, I just wanted to make the comment that I still find that hard. So looking at the map, you know, I would say those of us in Dallas have long sort of had the thought, well, we're the urban area, we're pretty centrally located to this entire map. If you look at the EMA HSDA, and obviously a lot of people are going to have to come into Dallas for services. So I mean, that's been sort of an outlook. As I look at this map, it strikes me that Rockwall is really the center of this map, that tiny little square county of Rockwall. But you know, so it's just it's always been so hard And I admire the people who work in the rural areas for what they do and how they do bring people in to Dallas, where most of the services are more centrally located. And there's, to my knowledge, there's very few services outstationed to most of those other counties. They either the funded agencies have services out there or they don't. I think there's maybe a little bit of outstationing, and I don't pretend to be aware of all of it. For Resource Center, we don't have any outstations set up in any county other than Dallas. So,
so it's very interesting. You know, I wanted to include this, and I'm going to keep pushing on it as we work our way through. You know, as we know, Dallas and Tarrant kind of sleep butt to butt. So, you know, there could be some folks that are going back and forth. You know, we also know that, you know, Norma's shop is the one that's northmost. And so if anyone has folks kind of coming across the Red River, it's likely her shop, but there could be others as well. You know, that's another key important factor for our geographic thinking, right? Like, what are our relative catchment areas? But then also, where does that catchment area like fall outside of our official, you know, zone? And I don't think that in the past, that consideration has been a handicap. But with Achieving Together and our state partners are really trying to get all of the AAs to think more as Texans, as Texas. And how are we scratching each other's backs? You know, are there people from the east of Kaufman County who kind of come over to get services because they're in a relatively unincorporated area of Texas that's part of TRG, which is focused on the Houston area predominantly, right? So like, we can think about how, you know, we serve our people, we serve our region, but we should acknowledge the fact that there are people that are moving around all the time. You know, even in the space of a year, they may actually have 3 addresses.
I think a growth area there, and I can't say that my agency's ready to step into this growth area, but, you know, for Ryan White purposes and for Part A, we actually have to be quite rigid about the residency of our clients, that they live in our EMA. And we tend to do the same thing with Part B, although Part B has said on occasion, the state has said, if they live in Texas, we're okay for them to be in your Part B services. That's a lot for a small agency or anybody to keep up with. And particularly when you have clients you're serving them on the same clients under Part A and Part B at different times. So, you know, we have some unused flexibility for, you mentioned people east of Kaufman, Michael, coming in to Kaufman for services. Under Part A, we have to be quite rigid about that. And no, we can't serve you in Part A. We tend to expect those, I am Norma, we tend to expect those same people, wherever they're getting their Part A services, well, get your Part B services there too. And that agency is probably, if they're funded for Part A and Part B, they're probably having the same client in and out in Part B. I don't have any solution to that. It's just sort of a remark more than that it is a barrier. And from our side, although we could serve broader territory apparently under Part B, that would, for the whole state, that comes along with a lot of extra attention and work that, you know, maybe we're not prepared to do.
Hey, I think there's a lot of, I know that Norma wants to chime in too. So I'm just gonna like really quickly say, it's really important that we meet ourselves where we're at. And we shouldn't tie ourselves to some standard of where we could or where someone says we should be. This is where we are. And so we're gonna go take a change management process to take practical next steps. Change is messy, you know? So I pulled up the pesky meatball chart to actually show we have a huge amount of overlap. Most of us that are funded by Part A to do a service are also funded by Part B to do the same service. And one of the areas that, you know, we're going to need to be thinking about a lot is what dollar pays for what client, or what dollar pays for what service, or what dollar pays for, you know, we need to be able to split this out a little bit better. And so,
Well,
you know,
and Michael, this is peculiar. It's unique to this program year because the AA really changed how they were funding different services from different pots of money. And I believe it's true that they spread it out very much more broadly so that for various reasons and good reasons. But I think if you looked at this picture a year or two ago, it wouldn't look like this.
very interesting.
And Norman, is that true for you? Or, well, maybe not for you, maybe more
He's in the
so.
Part B only.
Yeah, well,
The only one
because
part.
your funding is different. I would say if you looked at the Part A and Part B funding for the organizations that are in the Dallas CMA, this would have looked very different just even a year or two ago, and much less spread across. So that's something we're dealing with too. But anyway.
Just a little history on the Sherman Denison area.
Yeah.
We have 11, 12, 14 service categories. We truly are a one-stop shop, kind of by necessity. Because,
You're the only one.
yeah, because driving people 60 miles away, you're going to lose people. And it just became much more economical to just do the service there, or to subcontract it out. So that's kind of a history basis. But going back to actually Part B and Part D, 3 or 4 years ago, we approached Dallas County. We might even have talked with Dish, saying we're getting clients that are in Kaufman or in a county beside us in Texas, and we're having to turn them away. They want to come to us. They should be able to come to us. Why would you turn someone away saying, here, we can connect you up with someone else? If you have a client that wants to come, I think that is an opportunity to create viral suppression. They want to come. So we went, because yes, the requirements in the contracts with Dallas County were such that for Part B, they were very limited in the only counties we could serve were the 3 counties that were there. Yet, and that's how I approached Dallas County, Part B is for the whole state. That's how it's given. And I also found out that other EMAs were allowing their organizations, subcontracted organizations, to serve the whole state. Whoever walks in your clinic, if they say they're from Texas, you can take them in. We also went with Part D. We were finding that people who lived in the county in Oklahoma that's right beside us, those clients were, because actually it's closer to come to our clinic than to drive up to Tulsa or Oklahoma City.
Yeah.
We approached Part D and immediately, no, don't turn those clients away.
Right.
Yeah.
Yeah.
So there might be something, I don't know whether Part A can do that, but as I said, we went to Herson, to our project officers, and said, this is what's happening right now.
So as far as Part A, it was 1.5 years ago that Tarrant County got guidance from their Part A project officer, and they may have a different one from Dallas County, but it was actually the project officer's supervisor. He used to work in Austin. I can't remember his name.
Oh, yeah.
Mark Pepler?
Yes, Mark Pepler. Thank you.
Love him.
It was actually Mark Pepler who responded and said that Part A can serve anyone that comes to an organization. So Part A, last year, the Planning Council in Tarrant County voted to allow Part A funding to serve anyone in the state of Texas, just like Part B funding. So now organizations over there aren't limited as to where a person lives in order to provide services.
Love it. So we have our ECC to make these types of decisions and to advise the county leaders on what they can do. I believe Julie would have stepped out because she would have been giving us the high signs and like thumbs up and all that, based on other conversations I've had, with her about the state. But we have opportunities through the syndicate to be able to talk about those broader issues as well. But then I think it's really important. The most important piece here is the contract. Like, whatever is in the contract is what people feel beholden to. And we're actually kind of training you all now too, like, what's in the contract? You said that you would do this. And so it is only fair and reasonable and right for you to say, but the contract says I cannot do the things. So it's really, really, really important for, the county to hear and to understand and to feel this through your advice and guidance that, an input that you provide, and to see if there's ways that the county can clarify or streamline its contract to be more helpful to you all as a tool. Yes, I want to do what's right. Just please tell me what that is and I'm on it.
Yeah, I feel partially responsible for the change that occurred with the Part B funding, because I was kind of saying, how come we're limiting this? It really should be for the
There's
state.
Julie, hey.
Here's Julie. And I feel like the change occurred because the contract language changed. Because I was going, we should be able to serve anybody that comes in that lives in the state of Texas. That's what Part B is for.
Thank you, Norma. Norma
Oh.
always tells us what we need to do, and we try to do it. She is very engaged with quality, and I so appreciate her. And all of y'all are so engaged today. It's great to be here and hear all that's going on in Dallas and Sherman.
Well, I thank you. I mean, it's a more useful, more effective way of using Part B. And it's ideal for Part B. It's for the state. So thank you. It's helped out.
We're running late now, even beyond what if I hadn't messed up the invite. So I think we should wrap up now. But I think that this conversation has been extraordinary. And we have a lot to make updates on our framework documents. We have a lot of things to consider in our weekly CQM calls to discuss internally with our partners across the AA. And we have some additional thinking that we can do with our state partners. It's really great to have your input and your feedback on these different issues, and to know that you're supportive of us and are thinking as we're walking down this this pike with you. So thank you. Have a wonderful day, everyone. Thanks for joining us. We'll see you next time.
Bye.
Right.
Bye-bye.